Yeah, you can start.
सबको बंद कर दीजिए. Okay. So, good morning, everybody. So, in previous lecture, we see the myopia and hypermetropia, which is a spherical error. Spherical error means the power in all the meridians that is equal, and it is due to the even surface. But in astigmatism, it's a refractive error where reflection varies in different meridian. It means there is different power in at least two meridian. Therefore, the rays of light that enters the eye cannot converge to a point, but it forms two focal lines. So, types of astigmatism, the regular and the irregular astigmatism. Regular astigmatism, where refractive power changes uniformly from one meridian to another. But in irregular astigmatism, there is not the uniform change like in keratoconus. There is bulging of the cornea, but it is not necessary that bulging is in the center. It can be slightly in the bottom, resulting into the irregular surface, which results into the irregular astigmatism. Then the etiological classification, it is due to the it is due to the abnormality in the corneal curvature due to the lens, either change in the curvature of the lens, like in lenticonus, either due to the positional change in the lens, like in subluxated lens, or due to the retinal changes, like due to the oblique position of macula, or then types of regular astigmatism. First, it is with the rule astigmatism, where the vertical meridian is more steeper than the horizontal meridian. Second, against the rule astigmatism, where the horizontal meridian is more curved than the vertical meridian. Then third is oblique astigmatism, where two meridians are right angle to each other, but they are not at the horizontal and vertical plane. And then bi-oblique astigmatism, where two meridians are not at right angle to each other. Then optics of regular astigmatism, as we see that the parallel rays of light, these are not focused on a point, but it forms two focal lines. And when the rays of light passes through the astigmatic surface, it forms a specific arrangement of rays that is known as Sturm's conoid, which has two focal line and a circle of diffusion. Like we can see in the picture, there is point B where the vertical rays coming from the vertical meridian already focused, but the rays coming from the horizontal meridian are still converging. So we get the horizontal focal line. Then at point F, the rays from the horizontal meridian are focused, but the rays at the vertical meridian are diverging. So we got the vertical line. The distance between these two focal line is called the focal interval of Sturm, and length of this focal interval is the measurement of degree of astigmatism. Then at point D, we see a circle of diffusion, where the rays from the vertical meridian are diverging, and it is equal and opposite to the converging rays from the horizontal meridian. Now, types of regular astigmatism. First is simple astigmatism. Uh, there are two focal lines. There are two focal lines. If one focal line it converges on the retina and the other converges in front or behind the retina, that is known as simple astigmatism. If the other focal line converges in front of retina, that is simple myopic astigmatism, and if it converges behind the retina, that is simple hypermetropic astigmatism. Example of simple myopic astigmatism is -2 diopter at 90° or 180°. Then compound astigmatism, if the two focal line, both the focal line are either converge in front of retina or behind the retina. If both the focal line converge in front of retina, that is compound myopic astigmatism, and if it converges behind the retina, that is compound hypermetropic astigmatism. Then mismatched in this one focal line converges in front of retina and other behind the retina. Now the clinical features. There occur blurring of vision, astigmatic symptom, tilting of the head, especially in the oblique astigmatism to reduce the image distortion, and the half closure of the lid to make stenopic slit and thus cutting out the rays in one meridian. Then these are the investigations we perform in astigmatism, like in retinoscopy to determine the power, the keratometry and computerized corneal topography to know the curvature of the cornea, then astigmatic pen test, Jackson cross-cylinder test, Placido disc, and photokeratoscope. Now, the treatment of regular astigmatism, here we prescribe the cylindrical lenses. Small astigmatism should be treated only if it produces the symptom. High astigmatism should always be treated. The change in the axis of astigmatic correction or new astigmatic correction are poorly tolerated. So patients are advised to have a uh, period of acceptability. Then bi-oblique mixed and high astigmatism are better treated by the contact lenses. Now, surgical treatment. These are the names of the surgical treatment. We do incisional refractive surgery and laser ablation corneal refractive procedures. Then clinical features of irregular astigmatism. Here we see the defective vision, distortion of objects, and polyopia. Here treatment is by the contact lenses. Phototherapeutic keratectomy is done in superficial corneal scar and surgical treatment in extensive corneal scarring.
Okay, so now give me example like in prescription, spectacle prescription, each type of astigmatism.
Uh,
Go to the type of astigmatism or yeah. So
like simple
go to the
myopic astigmatism.
go to the next slide, so you will be understanding more. Next. Yeah, this one.
Okay. So simple myopic astigmatism example is -2 dioptric cylinder at either 90° or 180°.
Or can be at any degree, na? Not necessarily 90, 180. So when it is
Yes,
at 90 or 180, what will you call it?
Regular astigmatism.
Yes, correct. And any types of regular astigmatism? So what do you mean by
The
regular astigmatism?
the regular astigmatism when there is two meridian which is perpendicular to each other. One
Right.
is one it is in vertical meridian, other is it is in horizontal meridian.
Okay, go back to the previous slide of regular, irregular astigmatism. Yeah. So in regular astigmatism, there will be what is written? Uniform change from one meridian to another. So there is no issue of 90 or 180 in regular. It can be at any axis. Irregular, what happens is that the change in power is irregular between two axes. So you cannot definitely tell that these are the two, one is the flat and other is the steep axis in case of irregular astigmatism, because it changes for every meridian little bit. Okay, go to the next now. No. Show the after the astigmatism, regular, irregular, next. Yeah. So tell me about this, with the rule, against the rule. These are all types of regular astigmatism. Okay.
Yes, sir. Yes. So, sir, since normally our vertical meridian is more curved than the horizontal meridian due to the pressure of eyelid. So, if in error vertical meridian is more curved than the horizontal meridian, we call it as a with the rule astigmatism. For example, +2 dioptric cylinder at 90°.
Okay. And you said
For
normally vertical meridian is more curved. Why normally?
yes, sir, because of the pressure of eyelid.
But what happens at the age of say 60? What is more
So,
common, with the rule or against the rule?
against the rule.
So it's not normal that with the rule astigmatism is not normal at all ages. Younger age, we tend to have more of with the rule astigmatism, but usually in elderly, there is against the rule astigmatism. So throughout the aging process, there is more this thing conversion towards the against the rule astigmatism,
Okay, sir.
right? And then what is the oblique astigmatism?
The oblique astigmatism in this, it is not in the matlab, not a horizontal or vertical plane. Like the axis is not in the 90 or 180 degree. It is like in the 60 degree or 70 degree, like that.
So plus minus how many degrees around 90 degrees considered as with the rule or?
So plus minus 20 degree.
Okay, so if it is 70 or 110, it is still with the rule. Okay, but if it is 60, 50, 40, 30, then it is oblique astigmatism. Okay. Bioblique is when two meridians are not at right angle. So this is rare to have, and most often it is because of some trauma, or maybe early causes of irregular astigmatism where you may have bioblique.
Okay.
Because generally we don't see bioblique astigmatism, and it's difficult to measure also on the regular keratometer. Okay, the regular keratometers, you like the autoref which come with keratometer, you write K1 and K2. So what is K1,
Yeah.
K2?
So K1 is the vertical axis and K2 is the horizontal.
Yeah, can you repeat?
Uh, so K1 is the vertical axis and K2 is the horizontal axis.
Okay, and what is the axis given there in the keratometer? You have seen autoref K?
Yes, sir.
Because nowadays we don't use the manual keratometers anymore. We always
Sir,
use auto
auto.
keratometers.
Yes, sir.
Can
Yes, sir.
anybody else would like to speak? Come
Steeper
closer
axis.
to laptop and then speak.
Sir, steeper axis.
Yes. Hello. I can't hear.
So the axis, which we know that is the steeper one. The steeper axis is noted.
Can't hear. Can anybody properly tell?
So steeper axis is noted, which is more steeper. That is noted.
On the auto keratometer?
Yes, sir.
See, autokeratometers generally have settings. So some autokeratometers we can check whether it is, you can either put the steep or flat K in the axis. But the general default which comes with autokeratometer is that flat axis meridian is noted. Okay.
Okay.
So
Okay,
for
sir.
example, if the auto K, what is given in our papers is say 43 and 44 and axis given is 180. So that means the 43, which is the flatter K, is at 180.
Yes.
Got it?
Yes, sir.
Okay. And if suppose 43, 44 is written and then 90 is written, that means flat axis is at 90.
Okay, sir. Yes, sir.
Okay. Got it?
Yes, sir.
Yeah. So basically the steep axis indicates the plus cylinder, which will be there. Okay. And flat axis will indicate the minus cylinder.
Yes, sir.
Okay. So regarding the spectacle prescription, I think you told the right thing. What is with the rule astigmatism? Suppose a patient has -1 spherical and -2 cylinder at 180 degree. Then is it with the rule or against the rule?
So again, please आप एक बार फिर से बोलेंगे question spherical.
-1 spherical and -2 cylinder at 180 degree. Is it with the rule or against the rule? Why it is with the rule?
Because power in the horizontal meridian is more than the vertical meridian.
Yeah. So simple thing to remember is that if cylinder is plus and it is at 90 degree,
Yes, sir.
or cylinder is minus and if it is at 180 degree, it is with the rule astigmatism.
Yes, sir.
Okay. So most of the younger patients that we see, generally they have cylinder at around 180 degree. That you must have observed. Okay.
Yes, sir.
Minus cylinder at 180 degree is the common observation. That's because younger patients have more of a with the rule astigmatism.
Yes, sir.
Okay. So
Yes,
what
sir.
will be the against the rule astigmatism? Suppose patient has -1 spherical and -2 cylinder at 90 degree. Is it with the rule or against the rule?
Sir, against the rule.
Yeah. Why against the rule?
Because the conversion power is more in the horizontal meridian.
Yeah. Don't confuse yourself. Keep it very simple. Okay. I will tell you another thing. So minus at 90 degree. Okay. And
Yes,
plus
sir.
at 180 degrees against the rule. Okay. So simple thing to remember is that plus at 90 is with the rule. Okay. And rest everything you can extrapolate, like plus at 90 is with the rule, then plus at 180 becomes against the rule. Correct?
Yes, sir.
Minus at 90 degree becomes against the rule.
Yes, sir.
Got it? So remember one thing, plus at 90 degree is with the rule.
Yes, sir.
Got
Yes,
it?
sir.
Okay, in the spectacle prescription. Now let's come to the keratometry. Okay. Suppose keratometry is 43 diopters at 180 and 44 diopters at 90. So now it is with the rule or against the rule?
With the rule. With the rule.
Why?
So more power at vertical axis.
So steeper keratometry is at 90 degree. So it is with the rule. Okay.
Yes, sir.
So steeper keratometry is equivalent to plus in spectacle cylinder. Okay.
Yes, sir. Yes, sir.
Got my point. So why this is important for surgery? For example, if patient has, suppose I'm just giving example, patient has plus cylinder in specs at 90 degree, most likely he will be having steep axis at 90 degree.
Yes,
Got
sir.
it?
Yes, sir. Yes.
Oh, ठीक. Okay, go to the next slide. That diagram. Go to next. Diagram of different types of astigmatism. Now go to the, what is the difference between simple myopic and compound myopic astigmatism?
Sir, in simple myopic, the power in one axis is emmetropic. And in compound myopic, there is power in both the axes. Like, for example, in simple myopic, power is -2 diopter cylinder at 90 degree, but in compound myopic, there is power like -2 diopter cylinder in 90 degree and uh, -1 diopter cylinder at 180 degree.
Fine. Okay. And mixed cylinder?
So in mixed, we have like one power in myopic and one power in hypermetropia. In one axis there is myopia, and on other axis there is hypermetropia. Like plus 2 diopter in 90 degree, plus 2 diopter spherical, and minus 4 diopter cylindrical at 90 degree, for example.
Okay. So what is the clinical importance of mixed cylinder?
The transposition.
Yeah, transposition. And second thing is that you told about the area of least diffusion, Sturm's
Yes,
conoid.
sir.
So go to the
Yes,
next slide.
sir.
Okay. So you have area, which is the area of least diffusion.
Sir, T.
Yeah. So basically in mixed cylinders, many times we have this area on the retina. So
Okay, sir.
if patient has mixed cylinder and spherical equivalent is near to 0, patient may have better vision than having a compound myopic astigmat. Go to next slide. Go to the diagram again.
Okay.
Okay, because you can see the average of the two rays is nearer to the retina.
Yes, sir.
How do you calculate spherical equivalent?
So the spherical power plus half of the algebraic the cylindrical power.
Okay, so for suppose patient has -2 spherical and +2 cylinder. What is the spherical equivalent?
So spherical equivalent in that case would be -1.
Correct. Okay, suppose patient has -1 spherical and +3 cylinder.
0.5 plus 0.5 spherical power.
Okay, everyone understood that?
Yes, sir. Yes, sir.
Okay. So this is very important. So in simple myopic and compound myopic, the spherical equivalent always will be minus. But in case of mixed, it can be also 0. Of course, it can be also plus or minus depending on which is more, cylinder or sphere.
Yes, sir.
Fine. Okay. Go to the next slide. So now for treatment part, if we go to treatment part of the cylinders, let's consider only the laser refractive procedure. Okay. Then which of these will be easier to treat and which might be difficult to treat? Let's say astigmatic keratotomy. You want to do astigmatic keratotomy for a refractive error. Then which type of error can be corrected by astigmatic keratotomy?
Regular astigmatism can be better corrected with surgical treatment as compared to irregular.
That is obvious. That is different part. These are all for regular only, na? All these limbal relaxing and astigmatic.
Yes, sir.
Okay, so if you want to do only astigmatic keratotomy for correcting refractive error, then it can be done only for mixed astigmatism. Okay, when the spherical equivalent is near to 0.
Yes, sir.
Okay, of course you can add it along with cataract surgery where you are correcting, say, spherical also part. Same way limbal relaxing incision. Okay, now for laser ablation procedure, which of the types of astigmatism are easier to treat? So basically simple myopic and compound myopic are easier to treat because we don't need to treat any hyperopic component in that. Correct?
Yes, sir.
But in case of mixed or hyperopic, obviously we have to treat the hyperopic astigmatism also, that we can treat. But of course, myopic will be easier to treat with laser ablative procedures. Because in myopic laser aberration, we are treating the central part of the cornea, while hyperopic, we are treating the peripheral part. So peripheral part, when we treat, it's more prone for regression later.
Yes, sir.
Okay. Okay. Next, anything else? Slide is there? Any other slide?
No, sir.
Okay. One more thing about astigmatism is that how much amount of astigmatism you should treat. For example, patient comes with no symptoms at all, and on examination you find -0.0 cylinder. So will you give the prescription to the patient?
How much? Price?
0.5 cylinder.
If the patient is complaining of astigmatic symptoms, we should prescribe the patient whatever cylinder.
Correct. Okay. So why up to 0.5 cylinders patient generally do not have any complaints? Why is it so?
Accommodation.
See, that is one more important thing. The accommodation cannot correct astigmatism.
Yes, sir.
So mainly it is because of the retinal thickness. Okay. There is Stiles-Crawford effect. That means the macular photoreceptors can change the direction slightly. So if suppose there is 0.5, 0.75 cylinder also, if it is within the retinal thickness, because you know that retinal thickness is around 200 micron or 0.2 millimeter, which is equivalent to around 0.6 diopters, right? So if the light rays are falling whether on the surface of the retina or slightly deeper, still those rays will be considered as a parallel rays because the photoreceptors will change its direction. Okay, so retina has ability to correct that small amount of astigmatism.
Yes,
That's
sir.
why most of us on keratometry may have some astigmatism, but we do not accept the refractive error. Okay, because the retina is adapted to that. Another
Yes, sir.
retinal adaptation, you might find that on the objective refraction or autorefractometry or retinoscopy, you may have different axes. For example, say on autoref it shows 10 degrees, but patient is wearing 20 degrees axis since very long time. Then if you try to give him 10 degrees axis, he will not see clearly. But if you give 20, he may see clearly because his retina is now adapted to that astigmatism. Okay, so that is also another observation that we may encounter in the OPD. So that's why generally, if a patient is used to certain axis of specs in the specs, it is better to continue with that unless there is a gross change in the vision.
Okay, sir.
Okay, so that is what is written here also, fourth line, that change in axis or new correction is poorly tolerated. So unless it is significantly improving patient's vision, we should not try to change the axis of in the spectacles.
Okay, sir.
Okay. Then another issue is whether many patients, if they have very high cylinders to begin with, when they become presbyopic, they may have certain difficulties because with progressive or bifocal glasses, when the bifocal or progressive segment comes into picture, sometimes the distortion starts, particularly if they have high cylinders. Because in the area of transition, the astigmatism varies, right? So these patients may have difficulty in adapting to progressive glasses sometimes. Okay, so we have to forewarn them that this may happen. So they have to be they take more longer time to get adapted to that.
Yes.
One more important thing after prescribing the cylinder specs, okay, particularly in children and also in adults, it is better to have full frame or half frame glasses, okay, and avoid any frame that bends very easily. Like the metal frames are there, or sometimes, of course, now the new rimless spectacles are much better. So any frame that bends is a problem because you know the cylinder, if it changes by 10-20 degree, will have more asthenopic symptoms and loss of vision.
Yes, sir.
Okay, sir.
Okay, so spectacle troubleshooting is also very important in the OPD. Okay.
Yes, sir.
So Ankita, what are the common problems of spectacles that you come across? That patient come back with spectacle and they are not happy. Can you enumerate few?
So usually, the frame is of not proper size, then the centration of the glasses is not correctly done, and the placement of the glasses is not in the correct position by the patient. Like the children may not wear it in the proper position, so the vertex distance may change. That can also be one of the problem. And then the most common is the scratches on the glasses that can cause distortion and blurring.
Right. So most important, first, if patient comes back with problem in glasses, we have to recheck the refraction that it is correct. Okay. Many times there might be minor changes, 0.25 here and there, but that should not be the issue usually in patients. Okay. Second, rightly said, centration of glasses is the most important thing. And I would say 80-90% that is the cause of discomfort for the patient with the new glasses. Okay. The third thing, frame size, correctly said. Second, in frame size, frame type also, pantoscopic tilt. You know what is pantoscopic
Yes.
tilt?
Yes, the tilt of the glass from the temple area. There is a tilt, uh, like it is preferred for the bifocal glasses, but
Yes.
otherwise it should not. It should be less in the monofocal glasses.
Yeah. So there should be 3 to 5 degrees tilt towards the cheekbone. Okay, inferiorly. That is called
Yes.
pantoscopic tilt. And
Yes.
rightly said, for progressive or bifocals, it is very important. Otherwise, patient may have difficulty or have bending of letters, as they commonly tell that when I look at any book, the corners appear bent. That is because lack of that pentoscopic tilt, which gives them a kind of prismatic effect in the eye. Okay, while seeing these. That is
Yes.
third. Okay. Then next, you have already told about the. Then the fourth thing is you have to ask the patient to wear the glass and then check for the centration, because where should you
Yes.
know how to check the centration with
Uh,
torchlight or pen light?
yes, so we can.
How?
We can shine
Dhanraj?
the light and ask the patient. So we can shine the light and on in the center near the forehead of the patient, ask the patient to look at the distant, and then where the light reflex is falling, we can just see the pupil, the where the pupil is placed, and then mark it on the glasses.
No, no, that is okay. That you have marked the pupil, but how do you know it is the center of the glass, optical center of that specs or glass? How do you mark
Uh,
that?
we have to move the glasses, like if we have to consider a straight line, and along that we have to move the glasses. So at one point where there is least distraction of that line, that is the center point.
No, no.
So the edges
Anybody
of
else?
So any flat edges, the specs can be taken, one glass selected, and then if we want to make the lines that we can see through the glass parallel to the lines that we can see externally. So and just match the lines, and then we can do in both in 90-degree and 180-degree, and then the center of those 2 point lines would be the center of the glass.
No, no, simple. When the patient is wearing the glass, how do you check for the glass center of the spec? It's a very simple test to check that. You can mark the optical center in the lensimeter also. There is a provision to mark that. But how to check that way? Because when patient is wearing, at that time we have to know that pupillary reflex or the pupil center and that optical center of the spec should be matching within very short distance. Then only patient will be comfortable.
Okay.
So see, simple test is, you know the Purkinje images in the eye.
Yes, sir.
So there are Purkinje images from the reflection of the corneal surface, then lens, and then you know that. So similarly, when you shine a light on the any lens, okay, spectacle lens, you will find two images, one from the anterior and one from the posterior surface. Okay, and when you move the light, torch light, which is in front, say pen light or any point light source, then at a particular point, these two images or these two reflections will match.
Yes, sir.
That is the optical center of that glass.
Okay. Yes, sir.
In case of progressive glass, it will be like a line. There will be a vertical line because it's like changing from the center, from the upper part to the lower part. So it will be like a line. But for the distance, you can mark out 1 point. Okay, for mono glasses, monovision glasses, you can easily mark that.
Yes, sir.
Okay, so that is the optical center. Now, when patient is wearing glasses, you can check the optical center also easily and the pupil center also, pupil reflex also. So they should be matching with each other. Most common problem is when the optical center is temporal to the pupil center. If it is slightly nasal, generally patient tolerate better. But if it is temporal, they don't tolerate much. So then they have asthenopic symptoms.
Yes, sir.
Okay. So that is very important. You can easily check it while patient is sitting in front of you within just 30 seconds. Okay.
Yes, sir.
Then next common problem is with the progressives, that the distant area, the area for looking at a distance is slightly up. Okay. For example, if pupil is supposed to be there where the distance center is there, but if that distant area is slightly upward shifted when the patient is wearing specs, then what happens? The near segment or the intermediate segments comes in view of the patient.
Yes.
And these patients are most unhappy because their distance vision is now deteriorated.
Yes.
Okay, so that is the thing. So this is about presbyopic or bifocal glasses. And of course, then the progressive glasses need adaptation. Okay. The most common complaint that they have is that when they try to look at anything close by, they can't see properly. Now they have to lift that, thing up to see. This happens because like in previous glasses, if it is not progressive, they have a habit of bending their head down to look at near things. Okay. In case of progressive, you should not be bending your head, but you just have to move your eyes down. Okay. That is how you can use the near segment of the progressive glasses. So once they understand that, it becomes easy for them. Generally, climbing stairs down and climbing up, it is difficult for patients wearing bifocal glasses because they have to look through the distance area only if they want to this thing go up and down the stairs. So it is advisable that you tell them that look towards the stairs from the distance area, then only you will be able to climb up and down. Otherwise they can just remove the glasses and climb up and down. Okay, because that is the one major concern that these patients have.
Yes, sir.
Okay, got it?
Yes. Yes, sir.
Any other questions?
No, sir.
You had class on refraction already?
Not yet, sir.
Okay, so you can request science sir to arrange class on refraction sometime.
Yes, sir.
Okay, whenever he gets time.
Okay. Yes, sir.
Okay, I will just demonstrate you how to check the optical center. If you are not understood, I will come there and show you.
Yes, sir. Yes, sir.
Okay, chalo, we'll end the meeting now.